Hey guys, this is Miss Story, and I'm going to cover assessment of the nervous system, which is chapter 41 in your book. Some of this should be review for you because not only have you covered it in past lessons, like when you talked about stroke patients and TIAs or emergency nursing, but also because some of this you've been doing and didn't realize you were doing it since you started clinicals. Every time you go in and speak to a patient and observe how they interact with you or how they get up and move around, you're assessing that nervous system. So now we're going to put some names with that and focus that assessment. The health concepts covered in this chapter include cognition, mobility, and sensory perception. Cognition is their reasoning, their learning, their memory, and their personality. This is how they receive, process, and share information. So you'll not only be looking at how they receive the information you give with them and their level of understanding, but also are they able to correctly share information with you? Do they answer your questions with the correct words or words that you can understand? Mobility, of course, is affected by the nervous system, and then also their sensory perception, their touch, taste, smell, hearing, all of that is controlled by the nervous system. Our nervous system is comprised of two main areas, the central and the peripheral nervous system. Our central nervous system is composed of the brain and the spinal cord. And of course, the location of injury to the brain or spinal cord is going to dictate their symptoms. For example, if they had an injury in the temporal lobe, then we may notice some changes or difficulty with their speech. In your book on page 841, table 41, has a neat little chart that tells you some of the main functions of the lobes in your brain that you might find interesting to look over. The peripheral nervous system is composed of the spinal and the cranial nerves and the autonomic nervous system. And we're going to take a closer look at those. All right, your autonomic nervous system is divided into two parts. First, we'll talk about the sympathetic nervous system. That's your fight or flight. And I like to imagine that's what kicks in if you were, for example, running from a bear. If you're running from a bear, you're going to want your pupils to dilate so that you can see better. Your heart rate's going to increase so it can move that blood throughout the body. It's going to relax your airways. It's going to inhibit your stomach activity. Because you're not worried about digesting, you're wanting to save that energy so that you can pump it to your muscles and get away as quickly as possible. This nervous system runs on epinephrine and norepinephrine. In contrast, the parasympathetic nervous system is your rest and digest. This is what's going to kick in when you're sitting on the couch watching TV after a long day and you're eating a bag of potato chips. Your heart rate's going to slow down because you're relaxing. Your airways are going to constrict because you don't need to move that air as well because you're resting. Your stomach activity is going to kick in because you're digesting those potato chips. And this one runs on acetylcholine. And I feel like it's really important to understand how these nervous systems work because not only will you understand the symptoms when one of these are injured, but also the medications that we've learned so far, you'll better understand how they work and their side effects when you understand which nervous system they act on. For example, beta blockers or your epinephrine and norepinephrine. Just as with our other systems, age affects your neurological status as well. We need to set a baseline with these patients to determine their functional status, and that baseline includes noticing their motor changes, their cognitive function, and their sensory changes. Sensory changes as we age. There's going to be a change in your vision and your hearing, and your touch is going to decrease that touch sensation. So that those all combined may lead to an increased risk of falls. So we want to make sure that patients that are affected by that are on fall precautions. And their motor changes. They move slower. They have a slower response time. For example, if they trip trying to catch themselves, or whatever. And then cognitive function may be affected, but intellect does not decline. So Just because they may be processing the information you're giving them slower, or their short-term memory is affected, that does not mean that their intellect has declined. Make sure when you're with these patients that you take your time with patient teaching, because their processing times and their cognitive function does slow down. And it's easy for us to get in that patient room and just run through that patient teaching real quick and move on, because we've got a million other things to do. But we have to give these patients a chance to learn the medical care they need to give themselves, such as checking their blood pressure, checking their insulin, whatever it may be. So we need to make sure that we do our best to take our time, as their processing time slows, so that they can understand what we're trying to tell them. And remember that a decline in mental status, that's often an early sign of a disease or an infectious process. For example, we all know that UTIs, one of the first symptoms in UTIs in elderly is a change in their mental status. Also, an example I think of is I had a patient who had a sudden onset of dementia. And so we were treating them for their dementia, and they became very combative, and the family kept saying that it just was not like them. And we found out that it was actually a problem with their thyroid that was affecting their mental status. And once that problem with the thyroid was reversed, their mentation went back to baseline. So don't assume that just because they are forgetful or confused or agitated that it just comes with their old age. There's often an underlying problem that we need to address. Prevention of neurological problems starts with leading a healthy lifestyle, making good choices, and avoiding risky behaviors. Risky behaviors, that includes drinking alcohol in excess, and we make bad decisions, riding motorcycles without helmets, that kind of stuff, things that could lead to brain injury, um, and impairments in your neurological system. Proper nutrition. We need to make sure that we're getting a good balanced diet. A lot of the vitamins and minerals that we take in a good balanced diet, such as omega-3s or B12, they affect the way that our neurological system functions and transmits their messages throughout the body. And then healthy sleep habits. We need to make sure that we're getting good sleep, which is a lot of times easier said than done. I'm sure that as nursing students, you have seen firsthand the effects that a lack of sleep has on your neurological system, how it slows your processing time and it slows your reaction time. So we need to make sure that our patients are getting adequate sleep. Our assessment of the nervous system is divided into 4 parts that we will dig a little deeper into. Those being the patient history, that's setting a baseline and getting a background on our patients. Physical assessment, of course, that's our head to toe or our specific assessments on the neurological system. Psychosocial assessments, that's the decisions they're making in their life, where they come from, their environment that may be affecting their neurological system. And then the diagnostic assessment. These are our lab tests or our radiological tests, but we'll look at all of these in a little more depth. All right, the first stop in our neuro assessment is patient history, and I believe that a patient history is an extremely important part of this assessment. First, you want to get their medical history. Have they had any strokes? Have they had any problems in the past, any traumatic brain injuries? And then you want to get their medications. Uh, are they taking any medications that could be affecting their neurological status? Also, a lot of times a patient may forget something in their medical history that their medications will clue you in on. Assistive devices. Do they use glasses? Well, then we need to make sure that they have their glasses. Same thing with hearing aids. We need to make sure that they have their hearing aids because those are included in their baseline. Do they use a walker or a cane? Are they left-handed or right-handed? All those can clue us in on what's going on with our patient. Family history. Do they have a family history of migraines, of strokes, of epilepsy? A lot of these neurological disorders have a genetic basis, so we're going to want to know that. Um, Level of consciousness. You can judge their level of consciousness while you're sitting here and asking these questions. Is the patient normally slow to answer? Is the patient normally have a little bit slurred speech? These kind of things are going to help you establish a baseline so that later on, if your patient is suddenly weak in the right arm, or they sometimes mix their words up, you'll know, is this a new development or is this something that they had when they came in? All right, now it's time for our physical assessment. Now you can either do a complete neurological assessment or you can do a focused assessment. You can even narrow that down to a quick neuro check when you do rounds. It just depends on what's going on at the time and what's called for. Remember, when you're doing these neurological assessments, that you compare each assessment with their baseline. So that's why you need a good baseline between their right and their left sides and between their upper and their lower extremities. Are the symptoms generalized or are they focused to a particular area? Because your nervous system controls everything in your body, you can have symptoms that are either generalized or focused to one area, and we need to know that. Now we'll move on to our assessment of mental status. We're going to want to assess that level of consciousness. Is your patient alert? Are they awake and talking to you and know what's going on? Are they lethargic, meaning that they are drowsy, but you can easily wake them up and talk to them? Are they stuporous, meaning that you have to elicit a painful stimuli in order to get a reaction, or are they comatose, meaning that they are unconscious and not reacting at all? Oftentimes, if there is a change in a patient, especially neurologically, the first sign is going to be a change in level of consciousness. So we want to make sure that every time we interact with the patient, we are assessing their level of consciousness and making sure that there hasn't been a change. Now, while change in level of consciousness does often serve as the first indicator of a decline in neurological status, it also serves as a good indication for other problems that may be going on. So be mindful of other things that may affect these. What time of day is it? They're not going to be as alert at 3 a.m. as they were when you first got there at 7 p.m. Have they been able to sleep lately, or have they been in a lot of pain? What is their glucose level? Are they hypoglycemic? What is their oxygen level? We learned with shock that one of the big signs with a decrease in oxygenation was a change in level of consciousness. So you want to make sure to assess all these things and see if any of them have contributed to that change. When you check a person's orientation, I'm sure we're all familiar with this by now. You want to make sure that they can tell you who they are, where they are, what time is it, and what's going on. Now make sure, again, this is why you need a good baseline. Did your patient know what time it was when they were admitted? Or were they confused? Is that their baseline? Do they have Alzheimer's? So you want to make sure that you know where they were at so that you can tell where they're at now. Now we're going to look at assessing the cranial nerves. And let me tell you, you don't have to necessarily remember the names of these cranial nerves. What you do need to remember is their number, and they are numbered with Roman numerals. So if you need a refresher on that, make sure you look over that. You're going to need to know what they do, how to assess them, and what a normal and abnormal response is. So the first one is the olfactory nerve, cranial nerve 1, that assesses your sense of smell. I remember that because you have one nose. In order to test this, you're going to have the client close their eyes and then hold one nostril, and you're going to put a smell to the opposite side and have them name it, and then do the same on the other. Make sure that the nostrils are clean, they're not stuffy, or anything that would affect the results of the test, and that you use a smell that is easy to identify, like vanilla or cinnamon or coffee. Cranial nerve 2 is your optic nerve. That's because you have two eyes. So that's going to test your sight, and that's where you read that Snellen chart. And we've all gone through that before. So that's how you'll test their optic nerve. Cranial nerve 3, 4, and 6 all work together to move your eyes. You'll test those with the 6 cardinal fields of gaze, and that's where you will get a pen light and have them follow you with their eyes up, down, side to side, and then to the corner and the opposite corner. You'll also shine that pen light in their eye and assess them for perla, where their pupils equally round and reactive to light and accommodating with that light. And that's your 3 is the one that moves the pupils. All right. Cranial nerve 5 is the trigeminal nerve, and this is the sensory nerve of the face. It can differentiate touch, pain, and temperature. You can test this by having your patient close their eyes and you touch them on different parts of their face, and they let you know where you touch them. Cranial nerve 7 is the facial nerve, and this is the motor nerve of the face. You can have your client smile, raise their eyebrows, frown, puff out their cheeks, or squint their eyes. You want to assess that they're able to do this without any difficulty and that it is even on both sides. As you know, if it's not symmetric, then that could indicate things like a stroke. Cranial nerve 8 is your vestibulocochlear or your acoustic nerve, and that controls both your hearing and your balance. First, you can test their hearing with the whisper test. You will stand on the side of your patient, close the opposite ear, and whisper in the ear closer to you, and they repeat what you said, and then you'll do it on the other ear. For their balance, you can have them walk across the room and back, and you would assess their gait to make sure that it is steady and they're able to maintain their balance. Cranial nerve 9 is the glossopharyngeal. You can test this by having them open their mouth and say ah, and you want to make sure that you see their palate move evenly in an upward movement. You can also elicit their gag reflex, and you can also note their ability to swallow. Cranial nerve 10 is the vagus nerve. You'll assess this by also their ability to swallow and also their ability to speak. Make sure you can tell if there's any hoarseness with that. Cranial nerve 11 is the accessory nerve. You can have them shrug their shoulders against resistance, where you put your hand on their shoulders and try to shrug against you, and then turn their head from side to side against your hand as resistance. And finally, cranial nerve 12 is the hypoglossal, and that's their ability to protrude their tongue or stick their tongue out to midline and then move it from side to side. These are just a couple graphics I found that may help you to remember what each nerve does. The second one is a few little cheats that help you remember what each one is. All right, so now we'll test your knowledge. The question says, when assessing cranial nerve 12 in a client who has experienced a stroke, which task should the nurse ask the client to perform? A, focus on a distant object. B, stand with their eyes closed. C, turn the head to one side. Or D, stick out their tongue. As you can see, the answer is D, stick out the tongue, as cranial nerve 12 controls their ability to stick out their tongue. And this is just a kind of fun little video to help you remember these cranial nerves. When assessing motor function, there's a few things you want to look at. Firstly, you can assess their strength. As you can see, that's what they're doing in this picture. You can have them pull against your arms or push against your hands. You can also have them, you can test their grip against your hands. You can have them push up their legs while you push down on their shin. You can have them flex their feet upward while you push down. When you're assessing all of these, you want to make sure that the strengths are equal on both sides. Then you test their coordination. You can have them close their eyes and put their hands out to their sides and then alternate touching opposite fingers to the nose. You can also have them touch their nose and then your finger, and then move your finger, have them touch their nose and your finger to make sure that they can not only coordinate that movement, but that they can also cross the midline with their movements, because that's very important. You can have them put the palms of their hands on their thighs and then alternate flipping from the palms to the back side of their hand and see how quickly they can do that and if they can maintain coordination through those movements. Next is tone. Are they hypotonic, meaning that they are flaccid and there's not much tone when you go to move their arm? Or are they hypertonic? These patients you see when they have like contractures or like the children I've worked with cerebral palsy, is their muscle tone tight and it's hard to get them to be able to move their arms, straighten out their fingers. And then, as we said, symmetry. You want to make sure that what they can do on one side, they can do on the other. Uh, are they equally strong? Is their tone coordinated and equal on both sides? And then also their legs and their arms, are they equal in both strength, tone, and symmetry? Now on to the assessment of the reflex activity. And I wanted to add, when you're assessing things like the reflexes or the motor function, again, this is where a good patient history comes into play. To help you know if they're not able to do these things, is there something in their past that is causing that? For example, if their medical history includes arthritis or a broken leg, or they have high magnesium levels, that may affect their generalized reflexes or their strength or coordination in those affected limbs. So you want to pay attention to their medical history and also the medications they take when you're assessing these things. But on to reflex activity, again, you want to check for symmetry, make sure that they are the same on both sides. If they have um, an injury that is affecting only one side, that's going to let you know that something is off. Also, are the reflexes generalized in their deficits or their hyperactivity, or are they localized to one area? Hypoactive reflexes are usually a result of a damage to the lower spinal cord or to neuromuscular diseases, and hyperactive reflexes usually indicate damage to the brain or the upper spinal cord. And then also pay attention for clonus. Clonus is the sudden, brief, or jerking contraction of muscles, often seen in seizures. With your assessment of sensory function, again, you're going to be checking for symmetry on both sides. You can begin this with light touch. So you'd have the patient close their eyes and you touch them in different places with you can either use your finger or like the picture uses a cotton swab or a Q-tip. If they're unable to feel the light touch, then you can move on to um, getting a tongue blade, and you can try a dull, firm touch with the end of the tongue blade. And if that is unsuccessful, then you can move on to the painful stimuli. You can break that tongue blade in half and use the sharp end and test their pain sensations with that. But again, if they're able to process light touch, then there wouldn't be any need to move on to the painful stimuli. With a patient whose level of consciousness is more decreased, you may need to test that painful stimuli by maybe pressing on their nail beds or a sternal rub, anything like that. Next is the temperature sensation. Can they tell the difference between hot and cold on different parts of their body? You can also test vibration sensation. Can they sense vibration in different parts of their body? Positioning. That would be, for example, you could have them close their eyes and then move their finger up or down and have them tell you if their finger is up or down. Can they tell the position of their limbs without seeing it? Lastly is cortical sense, and that's being able to differentiate shapes. One way you can do that is to have them close their eyes, and you can use your finger to write numbers or letters that are easy to differentiate into the palm of their hand, and they tell you what you wrote. You can also try placing different objects in their hand, like a key or a quarter, and they tell you what you put in their hand. Note that problems that stem from the brainstem, the thalamus, and the cortex cause a loss of sensation on the opposite side of the body, like we learned with strokes. And Cerebral lesions result in deficits on the same side of the body. When assessing the cerebral function, you look at a few different things. Firstly, you can assess their coordination. We talked about a couple of these tests earlier when we talked about the palms up and down on their thighs, or the being able to touch their nose with their eyes closed. You can also have them run the heel of one foot up the shin of the other, and then do the opposite and check for symmetry, and they should be able to do that if their coordination is intact. With gait, you can have them, again, watch their balance as they walk, see if they're walking tiptoe or if they're dragging one leg. Those kind of things will key you in onto things that may be going on. With equilibrium, you can do the Romberg test. This is where you have the patient stand still and they close their eyes. You're going to stand next to them with your hands around them, so that way in case they lose their balance, you're there to catch them. And they need to try and stand that way for 60 seconds. And you're watching to make sure that they're able to maintain their balance. A little bit of swaying slightly is normal, but if they're swaying side to side and they're having to catch themselves, that would indicate a positive Romberg test. A positive Romberg test means that there's some deficit somewhere, whether it be an injury in the brain or even some vitamin deficiencies can cause that, like vitamin B. And let me point out that the problem will be on the same side as the cerebral lesion. Like we said earlier, if both lobes are involved, then incoordination will be bilateral. So all of that we covered is your in-depth, detailed neurological assessment. But oftentimes, what you're going to be doing is a rapid or focused neurological assessment. You may do these with your neuro checks each time that you go into a patient's room. Or if you're in the ER, you may have to quickly do a rapid or focused neurological assessment in an emergency situation. These neurochecks are done ongoing. Every time you're dealing with the patient, you're assessing their neurological status. You can do that while you're carrying on a conversation or while you're giving them their medications or getting their vital signs. It's an easy nursing intervention that you can do. And it's one of the biggest tools in our arsenal. A doctor's not going to be dealing with a patient or paying attention with a patient as closely or as frequently as we are. And as we talked about, a change in level of consciousness and neurostatus is one of the first signs that something is going on, and we're going to be the ones that catch that because we're the ones that are at the bedside most frequently. When you're doing your neuro check, there's a few things you want to look at. You're going to check their level of consciousness. Are they awake and alert, or have they decreased in their level of consciousness? Assess their orientation. Do they still seem like they know what's going on and where they're at, or are they becoming increasingly confused? Their movement, have there been any changes or declines in their movement? Their pupils, are they still equal, round, and reactive to light? And then the Glasgow Coma Scale. We're going to talk about that a little bit, and that is a scale that is used to assess for brain injury and their level of consciousness. So it is a numeric scale that is broken down into 3 parts, being the eyes, the verbal response, and the motor response. The scores range from a 3 to a 15, and that's a combination of those 3 parts. The first one, eye opening spontaneously, that's when you turn on the light or whatever, their eyes are opening, they're able to look at different things, that's normal. A 3 would be their eyes open to speech. That is, if you walk in and you have to ask them to open their eyes or call their name and then they'll open. 2, to pain. That means they don't open their eyes until you produce a painful stimuli. A central painful stimuli would be squeezing the trapezius muscle, applying pressure above the eye, a sternal rub. Now be careful that you're not causing any bruising, especially a sternal rub, and elderly patients can easily bruise. Now, of course, in an emergency situation, that's not the biggest concern, but still. And then a peripheral painful stimuli would be like pinching of the nail beds to try and get a response. Verbal response, a 5 is they are oriented to time, person, and place. Uh, 4 would be they're confused, but they're able to answer questions. So you may ask them what day it is, and it's a Tuesday, and they tell you it's Saturday. So the answers are confused, but they're able to answer, and it somewhat makes sense. 3 is inappropriate words. So you ask them what day it is, and they say pineapple. What they're saying does not connect at all with what you're asking. A 2 would be just mumbling, moaning, groans, not any real words coming out. And a 1 would be no response. In motor response, a 6 is they obey commands. They can do what you ask them. A 5 means they move to the localized pain. So if you're starting an IV in their right arm, they're able to move their left arm to push you away. 4 means they flex to withdraw from pain, meaning that they can't move to where the pain is, but any pain makes them flex and move away. A 3 is abnormal flexion. That's your decorticate posture, and we'll talk more about that in a minute. A 2 is your abnormal extension or your decerebrate posture, and 1 means no response. They are completely flaccid. So looking at these numbers, a 3 would be your comatose patient who is completely non-responsive, and a 15 would be your patient who is awake, alert, oriented, able to obey commands and open their eyes spontaneously. The saying goes, in 8, you intubate. That means usually a patient who is an 8 or below is imminent for intubation because they are at a lower level of consciousness and may have respiratory issues soon. All right, so this slide takes a closer look for us at the decorticate and decerebrate posturing. Decorticate, that is the abnormal flexion. They move their arms in toward the core of their body. That's how I remember it. This indicates problems with the cervical spinal tract or the cerebral hemisphere. The decerebrate, is abnormal extension. They move their arms outward. This is a problem with the midbrain or the pons. Now, when we're looking at these, one is worse than the other, as you saw from the GCS scale. The decerebrate is worse, and I remember this by the decorticate. They're flexing in towards their core, so they're still holding on. They're trying to protect that core, whereas the decerebrate, they're kind of letting go. They're flexing, they're extending outward. So those are your posturing, and I included some pictures of a real person because sometimes that's a little easier to understand than just seeing drawings. This is a video I found of a nurse explaining the Glasgow Coma Scale as well as displaying it on a patient. And she also does a good job of explaining the different types of painful stimuli. So I suggest you watch this, especially if you need a little more clarification to help cement this, because you're going to do your GCS scale every day, multiple times a day, and it's going to go in their charting when you do their assessment. All right, it is your turn to test your knowledge. You are assessing a 21-year-old male patient in the ER who has been found unresponsive and lying on the floor. The patient's father tells you that his son has been found collapsed in his bedroom, unresponsive. You try to stimulate him by performing a sternal rub, and he didn't open his eyes, but he does flex his arms inward towards his sternum. He does not verbally respond at all. What is the Glasgow coma score of this patient? Okay, did you get it right? The eyes are a 1 because there was no response. The verbal is a 1 because there was no response. And the motor is a 3 because he did the abnormal flexion or the decorticate response. So his total would be a 5, which unfortunately for this patient, a score of 8 or less, intubate. All right, now we're going to do our psychosocial assessment. The responses to this are going to vary depending on whether the condition is acute or chronic. For example, Did they have a CVA and they're dealing with a loss of independence? They're dealing with a giant change in their lifestyle. Or are they here for a back surgery that they're hoping will resolve the problem, and you're doing some training on this problem? You want to assess your patients for any psychological problems. Um, what are they living in at home? Are they in a stressful situation or abusive? Do they have a good support system? Do they use drugs or alcohol to deal with their problems? Um, are they depressed? As you can see, I shared one of the depression scales that you can use to assess for depression. All of these problems can affect their neurological assessment. So you're going to want to take these into consideration to see if they're affecting anything that you've seen. Diagnostic assessments include both your lab results and your imaging. Um, Fluid, electrolyte, glucose, oxygen, pH, carbon dioxide, all of these things, all of these levels can affect your neurological impairment. So we're going to be drawing a BMP, a CBC, an albumin, uh, checking for your minerals and vitamins, particularly that B vitamin like we talked about earlier, and your ABGs to see if any of that plays a role in their neurological status changes. Then we're going to be looking at your imaging, and we're going to break a lot of these down further in the coming slides. But for example, x-rays, they may be coming in with a head trauma and need to rule out a cervical spine fracture, so they'll be getting x-rays for that. You're going to want to make sure when your patient is getting any of these imaging assessments done that you are adjusting and preparing for whatever neurological problems they may have. Are they confused or combative? You may need more help getting them into the x-ray machine, or you may need to do an x-ray at the bedside instead of down in radiology. These things you want to plan ahead for. The next test we're going to look at is the cerebral angiography. And this is a procedure where the physician will go in through the groin, the femoral artery, and insert dye to look at the cerebral circulation to check for any blockages. When preparing this patient for this procedure, you want to make sure they don't have any allergies to the contrast agents. You want to make sure they are NPO for 4 to 6 hours before the test. Let them know that while they will be able to talk to the physician and voice any concerns they have, that they will need to be immobilized during the procedure. Because this is an invasive procedure, we will need to sign an informed consent and need to make sure to check that lab work. Check their serum creatinine to make sure their kidneys can handle the dye. After the procedure, we want to watch that dressing and maintain that pressure dressing for 2 hours on the site to make sure there's no bleeding. You can apply an ice pack to help with vasoconstriction and for any discomfort. They're going to need to keep that extremity immobilized, a lot like when they have a heart cath. Where you're going to be wanting to do routine neurovascular assessments to make sure that there wasn't any damage, that the blood flow is all good, check for level of consciousness, and remember, because they had that dye, we're going to want to hold the metformin. Next is a CT scan. These are pretty routine, and I'm sure you're mostly all familiar with this. This can be done with or without the use of contrast. It takes about 10 minutes per body site. So you're going to want to let your patient know that they will need to be still during the procedure, and that if they get contrast, again, we need to check for any allergies or sensitivities to the contrast. We need to check their kidney function. The CT scan can be used to check for any tumors, lesions, or in patients that may be at risk for a brain bleed, such as trauma patients or stroke patients. The MRI as a machine that's able to take a more in-depth look at the body than the CT scan, but it does take longer. I know an MRI of the brain itself takes about 30 to 45 minutes, depending on if it has contrast. These can be done with or without contrast, so you'll want to take into considerations the same things you did with the angiography, such as their renal function, any allergies or sensitivities to the dye, and you'll want to hydrate them afterwards and hold their metformin and recheck those renal labs 24 hours afterwards. You're going to want to assess for any metal implants, pacemakers, artificial joints, or heart valves, as this is basically a giant magnet. You'll also want to check the weight limits on the machines in-house. Most of the enclosed MRIs do have a weight limit. Now they do have open MRIs that they can use if they are past the weight limit or if they suffer from claustrophobia. However, the open MRIs usually don't take as good a picture as the enclosed MRIs. You'll also want to assess for claustrophobia, as this is an enclosed space. Patients that suffer from claustrophobia may need to be pre-medicated before the procedure to help them out with that. Now, they will have a call bell that they can call out if they have any problems. But as you can see, it is an enclosed space, and if they have an MRI of the brain, they will have this contraption on them like you see in the picture that will keep them from being able to move their head. So that can be a kind of scary situation for some people. I also take into consideration on your neurological patients. If they are combative or confused, they will definitely need to be pre-medicated. The PET scan is a test that uses the CT machine, and they inject a radioactive tracer that is used to evaluate drug metabolism and detect areas of metabolic alteration, such as in dementia, epilepsy, and Alzheimer's. The patient will need to be NPO before the test, and if they're diabetic, then they need to have the test done before they take their diabetic medications. It'll be about a 2 or 3 hour procedure where they will be blindfolded, and they'll have to follow some simple commands. So patients that have mental health or behavioral health issues may not be able to take this test. You will need to check the glucose before the scan because an elevated glucose level can affect the results. All right, this is the single photon emission computed tomography test, where radioisotopes are used to cross the blood-brain barrier. It is useful to test cerebral blood flow, amnesia, neoplasms, and patients in persistent vegetative state. It is not commonly used here, so this is one you probably won't see. All right, excuse me while I butcher this word, but this is the magnetoencephalography. It is similar to an EEG in that it monitors brain waves. You can see the brain in action with this rather than the still images of the MRI, and it is non-invasive. The EMG is used to identify nerve and muscle disorders and spinal cord disease. During this procedure, the doctor will basically poke the patient with needles in their muscles and then ask you to contract and rest the muscle, and they will record the activity on the computer. I have heard that this is an extremely uncomfortable procedure. The EEG is a test that you will most likely see locally in the hospital setting. It records the electrical activity of the brain and is commonly used in patients with seizure disorders. To prepare for the procedure, the patient needs to make sure not to use any lotions or conditioners of any type on their head. They need to make sure not to take any stimulants or sedatives 12 to 24 hours before. It is a pretty long procedure at 45 to 120 minutes. The patient must be still. This can be done at the bedside. They use a lot of glue to stick the probes on their head, so you need to instruct the patient on how to remove the gel or glue. One way to do that is witch hazel, and that will dissolve that glue or paste. The evoked potentials test is used to measure electrical signals to the brain generated by sound, touch, or light. It can also monitor brain activity in comatose patients. The one you see in the picture has a red dot on the screen, and the patient is asked to press a button every time they see that red dot, and they're just supposed to stare at that screen. Um, and they're able to watch the brain waves as the patient watches the screen. This can be used, for example, this one in MS patients. A lumbar puncture is a test where they can get a sample of spinal fluid and test that for different things. It is contraindicated in patients that have increased ICP or in patients that have a skin infection near the insertion site, because we don't want to introduce that bacteria into the spinal column. The patient will need to lie still in a position that bends the back as much as possible to ensure ease of insertion. The most common position they usually use is this side lying, as you see here, with the knees tucked up to the chest and the back bent as much as possible. Afterwards, you'll want to get frequent vital sign and neuro checks, as well as monitor for signs of increased ICP. Follow bed rest protocols. The patient will need to lie on their back to put pressure on that site and to ensure closure of the site. It depends on where you're at as for how long, but it can be up to 24 hours. You're going to want to monitor that insertion site. There will be either a Band-Aid or a dressing over it, and you're going to want to look for the clear drainage that shows that you've got some spinal fluid drainage, and if that happens, you want to alert the doctors. Monitor for signs of a spinal headache. Now, a mild headache can happen, and that can be treated with medication, but a spinal headache, I've heard, is extremely severe, and that is treated with a blood patch that is done by the doctor. One of the best ways to prevent a spinal headache is for the patient to follow those bed rest protocols strictly. A transcranial Doppler ultrasonography is basically an ultrasound of the blood vessels in your head, and it can check for any narrowing of those arteries. It is a non-invasive alternative to the angiography and can be done many times on the same patient. Now on to everyone's favorite part, the medications. A lot of these will probably be a review for you, but they are applicable to the neurological system, so we're going to go over those. Diprivan or propofol is a sedative agent used in general surgery as anesthesia, or used for ventilator patients to keep them sedated. It can be given as a one-time injection, like during surgery, or as a continuous infusion. It is a cloudy liquid, so if you see that, don't freak out. And one of the expected side effects is that it can turn your urine green, usually when you're getting that infusion. Now, you would still let your doctor know, but it is an expected side effect and not a cause of concern. Keep in mind a couple things when your patient is sedated. One, that they can still feel pain. So if they have a condition that is painful, then you would need to address that pain because the pain can still stress the body and cause more issues. And then also when you're doing that neuro checks and your Glasgow Coma Scale, that you indicate that their results may be different because they are sedated. All right, now we're going to look at diazepam or lorazepam, otherwise known as Ativan. It is a benzo used to treat anxiety, panic attacks, symptoms of alcohol withdrawal, or in patients with status epilepticus seizures, where they have prolonged seizures to help stop that seizure activity. You will want to make sure that you are assessing their vital signs because it is a depressant, and doing your neuro checks as well. This is given as an IV push. Phenytoin, also known as Dilantin, is a medication used to treat epilepsy or seizures, and it can be given IV or PO. The picture on the right shows gingival hyperplasia, which is usually seen in patients who are taking this long term, and that can be prevented by just good oral hygiene. Some of the other side effects you want to monitor for are headache, nausea and vomiting, constipation, dizziness, drowsiness. You're going to want to monitor their vital signs, and you're going to want to make sure that you flush before and after, just like you would with Ativan. You can also monitor a dilantin level, especially when this is used continuous, to make sure that it is at a therapeutic range. The normal dilantin level will be 10 to 20. Mannitol is an interesting drug. You've talked about it before when you talked about your burn patients. In this topic, we're going to use mannitol for patients with increased intracranial pressure. Mannitol is an osmotic diuretic. It is given by infusion, and what it does, you heard it in the name, diuretic, so it's going to pull fluid off the brain and into the cardiovascular system, um, thereby lowering that ICP. So whenever we're giving a diuretic, there are a few things we want to look for. Any diuretic, we want to check their renal function. Um, Patients that have chronic renal disease aren't going to tolerate this medication very well. You're going to want to monitor their electrolytes because the fluid is being pulled into their cardiovascular system. They're at risk for fluid volume overload, so you're going to want to watch their blood pressure and their heart rate. One way that you can make sure that this medication is working is to monitor their output. Because think about it, if we're pulling the fluid off the brain and into the cardiovascular system, that fluid's got to go somewhere. So just like any other diuretic, their urinary output should increase. So you're going to want to monitor their I and O's to make sure that that output is increasing. You're also going to be monitoring their ICP. That should be decreasing. Their level of consciousness should be increasing. And another thing about this mannitol is that it can crystallize in the container, in the vial. So you want to look out for any crystallization before administration. Sodium nitroprusside is a vasodilator. So it opens everything up, increases the blood flow. We've seen it used to treat hypertension. In neurological patients, a vasodilator can increase cerebral blood flow and get some blood flow to that ischemic area. Now, you do have to be careful because while it's increasing that blood flow, it can lead to increased intracranial pressure, so you'll want to monitor that. You'll want to make sure to monitor your vital signs closely while you're administering this medication. All right, that's the end of our content, so we're going to go over a couple questions. The client has just undergone computed tomography or a CT scanning with contrast medium. Which statement by the client demonstrates an understanding of the post-procedure care? A, I should drink extra fluids for the remainder of the day. B, I should not take any medications for at least 4 hours. C, I should eat lightly for the remainder of the day. Or D, I should rest quietly for the remainder of the day. The answer would be A, I should drink extra fluids. Remember, this patient is getting contrast, so we want to make sure to flush that contrast out and help our kidneys out. The nurse is performing a neuro check on a patient who has demonstrated a decreased level of consciousness. What is the best way to assess the patient's neuromuscular status? A, measure the patient's vital signs. B, test the reaction of the patient's pupils to light. C, check the patient's response to the stimulus of pinching. Or D, determine whether the patient is able to move his arms and legs. The answer is D, determine whether the patient is able to move his legs and arms. Now, you wouldn't want to start out with that painful stimuli before assessing if they can respond to verbal commands. Now, of course, if he was unable to move his arms or legs or respond to verbal commands, then you may want to progress down that chain to light touch or firm touch or pain. All right, guys, we made it through this neuro lecture. I hope that it made sense and it stuck with you. I want you to think over the material that we've covered and jot down your muddiest point. That would be the topic that just did not click, it didn't make sense, you don't quite get it. and bring that to class with you so that we can discuss it. Remember, no question is a dumb question, and what you may be having problems with may be something else that someone else needs to have explained further.